Hello and welcome to the 2015 CROI here in Seattle, Washington. My name is Christopher Brennan here for IFARA TV. And with us today we have Jeremie Guedj from the French National Institute of Health, INSERM. Jeremie is going to talk to us a little bit today about hepatitis C analytic modeling and how that can help us reveal new basic research about hep C and treatments and potentially cures. So Jeremie, if you can tell us a little bit about yourself and how you ended up here in your research in your lab.
Sure. So I'm a mathematician and a statistician by training, but I've always been interested in the biology and the medical research. So I did a PhD in 2003 in the south of France in biostatistics to understand the determinants of the change in HIV viral load. After my PhD, I moved to Israel and then to Los Alamos National Laboratory in New Mexico in order to apply this kind of knowledge to hepatitis C. And I started my work on hepatitis C when all this new treatment that we call direct-acting antiviral agents kind of bloomed. So yeah, I was involved in the analysis of several treatment and the understanding of the response to several different molecules in the field of hepatitis C. And so usually, I mean, in the last 5 to 6 years, I was mostly involved in HIV, and that's actually my first CROI, because I thought it was also interesting to get closer now to the HIV community, because we share a lot in terms of course, the population of the patients, but also all the methodological aspects which I'm primarily involved. So basically, both in HIV and in hepatitis C, you rely on the change in the viral load concentration to evaluate if a treatment is working, if a patient is responding. So, I mean, it's very close communities.
Mm-hmm. And can you explain a little bit about why we look at the concentration of viral load?
Yeah, so the concentration of the viral load, it measures how much virus a person has in the blood. So obviously it has to do with the severity of the disease. And when you start a treatment, so in HIV you want to maintain this viral load undetectable for as long as possible. In hepatitis C it's a little bit different because you can cure the infection. So the objective is really to bring down the viral load to such a level that actually you could consider that the patient is cured. So basically that you are able to maintain. So you start a treatment, you observe the viral load. At the end of the treatment, you expect that your patient has an undetectable viral load. You stop the treatment, you wait for a few weeks, 3 to 6 months. And if at the end of the 3 to 6 months without treatment, the viral load is still undetectable, then basically we say that the patient has cured a sustained virological response, which is a synonym for a cure, actually.
Mm-hmm. And has there ever been any research to your knowledge or any case studies where after that time the viral load maybe had a resurgence?
So I think there are some papers in the literature showing that in some cases there is what we call some kind of blips, so very small resurgence of virus. But I'm not aware myself of patients that relapse, that's the term that we use, that relapse very long after the end of the treatment. Usually if a patient didn't relapse in the first 6 months following the treatment, he's considered as cured. Now maybe there are some cases, there are always some very strange cases, but I don't think that it's a very frequent phenomenon.
Mm-hmm. And so in your mathematic modeling, can you tell us a little bit about what the process is like to do the kind of mathematic modeling that you're using? I assume you have some kind of sophisticated statistics software that you're using.
Yes. So basically the models that are behind come from the epidemiology. In biomathematics there have been what we call the prey-predator model, where basically you try to understand the interaction in a population, let's say, between the prey and the predator. So it can be, I don't know, fox and rabbits, this kind of thing. So it's the kind of model that comes from there, from the epidemiology. And in the 90s, some people had actually the idea to apply this kind of interaction between prey and predators to infectious disease, and especially to HIV, because in a way, the virus and the target cell, so essentially the CD4, kind of have the same kind of interaction that you can find in an ecological system. So they came up with these systems of differential equations, and one of the first findings was to consider that basically the viral load that you observe in a patient reflects a very dynamic equilibrium between the virus and the immune system. So if you take a patient, an untreated patient in chronic infection, it could be HIV, HPV, HCV, the viral load is constant. So for long, when people saw a constant viral load, they thought, well, not much is happening. Actually, if you have a dynamic point of view, you understand that actually it doesn't mean that nothing is happening. It means that there is a very balanced equilibrium between the virus and the immune system. So it can be kind of a low-intensity equilibrium, which means that you have a small number of virus produced every day and a small number of virus eliminated every day. Or it can be a highly dynamical equilibrium, high rate of production, high rate of elimination. So actually, when the first potent treatment against HIV started, by analyzing how fast the viral load was declining after the initiation of treatment, they were able to estimate the clearance rate of the virus, so the turnover of the virus, what was the half-life of the virus, how long a virion particle would live in the blood. And using these kind of models, they estimated that the half-life of the virus in the blood was extremely short, something between 2 and 6 hours. So that means that in order to maintain a very large quantity of virus in the blood of a chronic infected patients, that means that you need huge production every day of virus and elimination. So basically, this chronic phase should be seen not as a dormant or a silent infection, but as a very intense battle between the immune system and the virus. As a result of which, that also could explain, back to the 90s, kind of the progression towards AIDS. Because AIDS actually doesn't mean that the infection is wakening up in a way. It just means that it's the outcome of several years of intense battle between the virus and the immune system that kind of exhausted the immune system.
Right.
So that was So that was one of the most important finding of mathematical modeling back to the mid 90s.
And so when you're using these models and you make connections like that, what's the process like to leap from taking that kind of a connection and then going to basic biologic targeting to try and find targeted areas to affect the changes?
So it really depends what's the objective of the project. But what we did in the last years essentially was to get viral load data from patients starting a treatment and then trying to use this kind of models in a more or less complex fashion. And so once we have the biological model, we have a software that can predict for a given model and the given value of the parameters of that model what is the viral load. So we have softwares that can try to find the best match between the model and the data. So basically estimating the parameters that would allow you, that would allow the model to match exactly the data and the viral kinetics that you observe. So that's statistical software that are based on data fitting.
And do you have a favorite software package you like to use?
Yes, so I mean in the last years, one of the softwares that we use the most is called Monolix. So it's a software that not only helps you building the mathematical model, but also helps you estimating the parameters. And this is difficult because in the field of clinical pharmacology, what you frequently see is that all patients are different. And therefore, there is a lot of variability between patients. So when you analyze the response to a treatment, you don't want only to understand kind of the mean response to the treatment or the median. You don't want only to understand the typical patient or the average patient. You want also to understand how it might differ from one patient to another.
Looking for the outliers.
Exactly.
Yeah.
No, I mean, not necessarily the outliers, but at least the range in the response. And to do that, you need to have statistical softwares that take into account the fact that you have some distribution of the parameters in the population, and you want to use statistical software based on this kind of theory, which is called nonlinear mixed effect models, to take that into account. Nonlinear mixed effect models.
Okay.
To take that into account appropriately.
And is that a sophisticated set of algorithms to get that?
So the theory which lags behind is pretty sophisticated, but the use of the software itself is not.
Okay.
But I mean, it's like everything. You need some experience and training, because the question is not so much to click the button, but it's after to make the correct interpretation.
Right, to understand what you're clicking about here.
Yeah, exactly. But I mean, definitely, what I think would be very nice, and I think it's something that is possible in the near future, would be to have some tools that the clinicians could use to make the modeling himself, and basically observing the kind of the viral kinetics decline in a patient, and say, you know, using, I don't know, an iPhone or a kind of tablet like that, it would be very easy, because from a computational point of view, it's not necessarily very greedy or demanding. So using this kind of software that he could use to optimize the treatment duration on a real-time process.
Right. And this is using the same core concept of the predator-prey model when you're optimizing?
Yes.
So what does it end up looking like? I'm just curious about the output of the modeling software. What does it look like?
Well, basically, it looks like a curve going through the viral load data of a patient.
Okay, yeah, okay. And, well, I was wondering also, what have you seen here at the CROI that may have been something interesting to you or surprising to you?
Yes, so there are several things that I find very interesting. The first one is this notion of pre-exposure prophylaxis that can protect the patients. I think it's in a way it's very counterintuitive or very surprising finding, I would say. And it's also nice because it's not only a question of basic science. If you want this kind of strategy to work, you really need to bring together not only the clinicians, but also the policymakers, the NGO, I mean, every kind of people that are in connection with the patients, because you don't want the message to be, you know, wrongly understood and, you know, take a pill and do whatever you want.
Right.
So it's really fascinating, not only from a scientific, but also from a more public health point of view.
You need to end up having some kind of harmony within the whole health system for it to work.
Yeah, harmony and understanding between the different actors, yeah, definitely.
Yeah, absolutely.
Yeah.
And do you think that your modeling might move anywhere beyond HCV?
Yeah, so we have a modeling in different in fields of infectious disease. As I said, it started in HIV. Then it has been very popular in the field of HCV because all of these new drugs that came up. There are also modeling going on in influenza, and yeah, we might. I mean, we want to apply it to different infectious diseases, and yeah,
yeah. So, in the last couple of years, there have been developments in treatments for hepatitis C, and those developments have really changed the game for treating a patient, actually being able to cure them and making it a lot less rigorous and painful. I know that you're not an expert in the medical, treatment of patients, but do you have any insight that you can give to the audience about what those new drugs are and what they're about? Why are they so much less burdensome for a patient to use?
For a very simple reason, that it used to be that you needed weekly injections of what we call pegylated interferon for about a year. And after a year of these weekly injections, you only had, 50% chance to eradicate the virus. And not only it was, injections, subcutaneous injections of this treatment, but it was also going with a lot of side effects, kind of flu symptoms. So a relatively painful treatment with a very modest outcome. Now the game has completely changed because, as you pointed out, it's only oral drugs, so you can take the pills home. In some cases, it's 1 pill a day, and it's for between 12 weeks. It could be even shorter. Yeah, it's 12 weeks now. It could be probably 8 weeks in some patients, and we even have the expectation that it could be even shorter, at least for some patients, not for the most severe patients, but for, in a way, the easy to treat patients, it could probably be even shorter than that.
And can you tell us what role your expertise, the mathematic modeling of this, played in the development of those new drugs?
So it plays at different stages. When we are looking at the very early aspects of drug development, so it can be in vitro. So in that case, that's going to be, understand the relationship between the drug concentration and the effect that you observe in vitro. When you have very early phases of clinical development, you don't have a lot of patients, but you can have very detailed kinetics for these patients. So in that case, we try to understand how the viral load is changing, what does it tell about the appropriate dosing of the drug that you should give, get a first rough estimate of the treatment duration that will be needed with this drug. And of course, when you're going to a larger phase of clinical trials, such as phase 2 or phase 3, then it's a little bit more difficult from a kinetic point of view because you have a lot of data points, a lot of patients, but you don't have a lot of information per patient, because that would be just too expensive to have very detailed kinetics for 100, 200, or 300 patients.
Right.
But in that case, the nice thing is that we can use the fact that we have a very large population to, as I pointed out earlier, understand how the variability is in the response and get an even more precise understanding of what could be the appropriate duration of the treatment and these kind of things.
And I guess one last question: do you think that is the French National Institute of Health doing anything that you've seen internally that might be novel or unique compared to what other countries are trying to do to affect HCV?
So the French National Institute of Health, is a research institute which is present. We have labs in every university hospitals. But the National Institute of Health, its role is not necessarily to run a clinical trial. The clinical trials are run by the clinicians in the hospitals. So there have been a lot of things going on in the field of HIV and hepatitis. I mentioned to you this pre-exposure prophylaxis. There was a big trial run in part by INSERM and by the National Agency on HIV on this pre-exposure prophylaxis. We also were among the first ones to give protease inhibitors in the real life. So basically, in 2011, 2012, we had results from the clinical trials with protease inhibitors. But the big question was, okay, how representative these clinical trials are from the real life? Because the patients that you see in the hospitals are not necessarily the one, kind of well selected that you observe in the clinical trials. And one of the interesting findings was to show, for instance, that actually you had a lot of lack of tolerance of this treatment in the real life, because these patients had a much more problems of liver disease than what was represented in the clinical trial. So this kind of things. So there are basic research and clinical research conducted. Yeah.
Very interesting. Well, I hope you all the best in your research.
Thank you.
For all of our sakes. And that the modeling goes well and you find some novel targets.
Thank you.
And we'll be watching your research to see how it progresses.
Okay.
Thank you very much.
Thank you. You're welcome.